Document dressing change. In Epic Click Notes, click Procedure tab and New Note. In the New Note in the Smart Text box, type PICC dressing and click on Dressing Change option. Add documentation regarding placement of the line prior to and after dressing change. Central line imaging in neonates, radiographic views, and acceptable line positions. Upper extremities, SVC lower extremities, IVC upper extremities, midline subclavian, lower extremities midline at the level of mid-femur. 2 views, anterior and lateral views. There are occasions when 2 radiographic views, an additional lateral view, are helpful in determining line position. Positioning of upper limb PICCs. It has been shown that upper limb PICC line tips can move up to 2 to 3 vertebral bodies on adduction of the arm. Example of how line tip moves depending upon whether arm is abducted or adducted in upper limb PICCs. Lines which are looped, coiled, and not seen in single view. Upper limb PICCs. Posterior entrance of erroneous intra-arterial catheters. Malposition. Example of how line tip is in spinal vein view. What do you think of this view? Is the line in the right position? What would you do? In these pictures are the example of malposition of central catheters, PICC. Malposition occurs when the catheter tip is located outside the vena cava, often related to the insertion vein and venous anatomy. In neonates, malposition is reported in up to 10% of insertions. Common malpositions include internal jugular vein, axillary vein, contralateral brachiocephalic vein, subclavian vein, other aberrant veins. For example, arm and scalp, insertion sites, ascending lumbar vein with saphenous vein insertions. Asymptomatic malposition is possible. Looped catheter. Retracting the catheter may straighten out the loop. Infusion. Only saline solution should be infused until correct placement is confirmed. If the catheter is in the internal jugular vein, elevate the head of bed. If the catheter is in the contralateral brachiocephalic vein, position the infant on the ipsilateral side with head of bed elevated. For catheters curled in the axillary vein, place the contralateral side down with head of bed elevated. X-ray must be repeated within 24 hours. Repositioning. Catheter may be retracted, measured, and used as a midline or mid-clavicular catheter if appropriate. X-ray guidelines for PICC insertions. Arm insertions include the upper portion of the extremity, chest, and neck in the X-ray. Leg insertions include the upper leg, abdomen, and chest in the X-ray. Scalp insertions include the upper neck and chest in the X-ray. Radiopacity. Catheters are radiopaque and can typically be seen on the X-ray unless the infant has opacified lungs. If catheter tip is not visible, a water-soluble radiographic contrast medium may be used for better visualization. Where is the PICC line in picture 1 and 2? Positioning infant for initial and follow-up X-ray. For arm PICC X-ray of the AP view, both shoulders abducted to 30 degrees. For lower limbs position, frog leg. Initial X-ray is AP view and dorsal decubitus. PICC line insertion issues. Failure to advance the line. The PICC line does not advance as far as anticipated. Improper placement on X-ray. The PICC line does not cross the midline, failing to lie to the right of the spine. Unexpected kink or deviation. The PICC line shows a kink or deviation from its intended path on X-ray. Lateral X-ray findings. A lateral X-ray may demonstrate the line deviating posteriorly. These two X-rays show PICC lines that have entered the left lumbar vein. Malposition. Line not crossing the midline. In both cases, the line has not crossed the midline and lies to the left of the spine. If tip placement is in doubt, a lateral X-ray view may be helpful in confirming the venous location of the catheter tip. New dressing protocol for catheter insertion. As we implement a new dressing protocol for catheter insertion in our most vulnerable patients, our neonates, this update comes as part of our ongoing commitment to improve safety, reduce complications, and provide evidence-based care, particularly for our preterm infants. Let's begin by addressing the differences based on gestational age, which is critical when considering skin integrity and the risk of chemical burns. For infants less than 26 weeks gestation, we will now be using betadine for limb preparation, followed by a gentle application of betadine solution at the puncture site. The emphasis here is on tap, not rub. This minimizes skin trauma. After 30 seconds, we'll follow with saline wipes to remove any excess alcohol and reduce the risk of skin burns. For infants greater than 26 weeks, we'll use a chlorhexidine alcohol solution, again with the same technique. Tap, not rub, and rinse with saline after 30 seconds. This ensures we maintain antimicrobial protection without compromising delicate skin. Now, during the procedure itself, we're introducing a couple of key changes. First, we will verify catheter tip position using ultrasound when available. X-ray remains an option if ultrasound is not feasible. Second, after insertion, a drop of cyanoacrylate glue, specifically 2-octyl cyanoacrylate, will be placed at the insertion point. This step reinforces securement and acts as a barrier to infection. After insertion, we will cover the catheter up to the hub using a semi-permeable transparent polyurethane dressing. This dressing offers excellent visibility and moisture control and should only be changed if it becomes soiled or detached. Finally, for ongoing monitoring, we will check the position of the catheter tip with ultrasound or X-ray within 24 to 48 hours post-insertion, and then continue with weekly checks to ensure optimal placement and prevent complications. These small but vital adjustments can have a significant impact on outcomes. As always, our top priority is ensuring the safety and comfort of our patients. Your attention to detail in following these new steps will help us maintain high standards of care, reduce infections, and protect fragile skin during these critical interventions. Here is the link to review how to use secure port glue for PICC line.